Okay, let's unpack this. Imagine a silent threat, a common virus that, well, while it's usually harmless to adults, it can have profoundly serious consequences for a developing fetus.
Hmm.
We're talking about cytomegalovirus, or CMV. It's the leading non-genetic cause of congenital sensorineural hearing loss and also neurological damage in newborns.
Yeah, it's significant.
So for healthcare professionals like you, deeply involved in pregnancy care, this isn't just some clinical detail, it's a profound public health challenge with a very real human impact.
Indeed. And while, CMV infection during pregnancy might seem rare if you look just at severe outcomes on a population level, its individual impact can be absolutely devastating for families.
Right.
So this deep dive focuses on a really critical question being debated right now in France.
Hmm.
Should systematic screening for CMV infection during pregnancy be, well, universally implemented?
Because we've seen conflicting recommendations, haven't we? The landscape is definitely shifting.
It really is.
Precisely. So our sources today include these key reports from the Haut Conseil de la Santé Publique, the HCSP, that was back in December 2023. They laid out some pretty compelling arguments against widespread screening at the time.
They did, yeah.
But then, crucially, we have the very recent recommendations from the Haute Autorité de Santé, the HAS, from just June 2025, which present a compelling
A
reevaluation.
real shift.
Exactly. So our mission here is to guide you through these complex, evolving perspectives, helping you understand why the arguments in favor of systematic screening are gaining such significant ground in France today. So what stands out to you, the listener, as we start this exploration?
Maybe start with the virus itself.
Yeah, good idea. To begin, let's just lay the foundational science. CMV is incredibly common. It affects somewhere between, 0.5% to 2% of live birth,
That's the range, yes.
and it's transmitted through various body fluids. But what's particularly challenging, I think, is that even having had it before, prior immunity, it doesn't guarantee protection against transmission to the fetus.
Absolutely. Reinfections with different strains or even reactivation of latent strains are possible. It's a really stealthy virus.
It really is, isn't it?
It absolutely is. And what's fascinating here, or maybe concerning, is the distinction. While maternal primary infection, especially in the first trimester, is associated with a high risk, we're talking up to 40–50% of infected neonates developing sequelae.
Which is huge.
It is huge. But we've also learned that the risk of long-term sequelae is significant following non-primary maternal infections as well,
Yeah,
and often with similar frequency and severity.
right. So it's not just the first time.
Exactly.
Yeah.
This really highlights why managing any maternal infection is crucial, not just a first exposure. And these sequelae could be severe, things like sensorineural hearing loss, which can be progressive or fluctuating, and severe neurological damage like cortical necrotic areas or white matter abnormalities. These are often linked to infections acquired early in pregnancy.
So for years, despite that potential severity, the official stance, like the one from the HCSP in December 2023, leaned against systematic screening. Why was that the position? What were the main dilemmas they were grappling with?
Well, the HCSP raised several important questions and concerns back then. Firstly, they looked at the, let's say, modest public health impact in France in terms of numbers, noting that severe cases were relatively rare at a population level, estimated maybe 1 to 6 per 100,000 newborns.
Okay, so relatively small numbers overall.
At the population level, yes. But beyond the epidemiology, a major hurdle was the uncertainty around the efficacy and, critically, the long-term safety of valsiclovir, which is the main therapeutic option we have.
Right, the treatment itself was a question mark.
Exactly. They pointed to the Shaharnasan randomized controlled trial. Now, it did show a reduction in maternal-fetal transmission. It dropped from about 29.8% down to 11.1% for first trimester primary infections, which sounds good.
Yeah, that sounds promising.
But, and this is the key part, it had not clearly demonstrated efficacy on the actual frequency of congenital CMV infections, or importantly, on the occurrence of severe sequelae in the infected children.
Ah, I see. So it stopped some transmission, but didn't necessarily prevent the bad outcomes in those who still got infected.
That was the interpretation at the time, yes. And crucially, long-term follow-up data for children exposed to valsiclovir in utero was still lacking. We didn't know the long-term effects.
That's a significant point, an intervention reducing transmission, but without that clear proof of impact on the severe outcomes. Okay, so beyond the clinical efficacy, the HCSP also raised some big practical concerns about the screening itself, didn't they? What were those hurdles?
Yes, they did. And this raises the important question, how reliable are the tests and what are the implications for pregnant women?
Right.
The HCSP noted the delicacy of interpreting the serological tests, IgG, IgM avidity tests. IgM in particular can hang around for months or even years
Oh,
sometimes.
really?
Yes, which can lead to potential false positives. They estimated that maybe up to 22,000 women could be wrongly worried by false positives every year in France.
Wow, 22,000. That's a staggering number, isn't it?
It really is. It highlights the immense emotional burden that kind of screening program could inadvertently create if it's not managed very, very carefully.
Definitely.
And they also emphasize the very short window of opportunity for intervention. Ideally, treatment should start within 8 weeks of the maternal infection,
Okay.
which practically translates to maybe only a narrow 3 to 5 week window from the actual contamination to getting treatment started for it to be effective.
That is tight. Very tight.
Very tight. So this timing challenge, coupled with concerns about significant patient anxiety and also an observed increase in medical terminations of pregnancy, IMG, for CMV, even for non-severe cases,
Yeah.
all that contributed to their cautious position.
And nobody else was doing it routinely either.
Right. At that time, no country officially recommended generalized screening.
So, okay. The HCSP's cautious approach seems well reasoned, based on the data and the practical issues as they saw them in 2023. But then the HCSS came along in June 2025 with this new evaluation. And here's where it gets really interesting because you said this wasn't just an update, it felt like a paradigm shift. What changed? What was the central piece of new evidence or maybe reinterpretation that really shifted their perspective on velociclover?
You're right. It really was a pivotal moment. A significant factor was absolutely the reevaluation of Velaciclover's efficacy. The HASAS conducted a much more comprehensive analysis. They integrated that Shaharnasan trial data with 4 additional observational studies.
More data points.
Exactly. More data, a broader view. And this expanded data allowed them to conclude that velaciclover at the AG per day dose, taken until amniocentesis, is actually effective in reducing the risk of vertical transmission.
Okay, so a stronger conclusion this time.
A much stronger evidence-based foundation for intervention than we thought we had before. And moreover, there was a pharmacokinetic study too, which confirmed that velaciclover concentrations actually reach the amniotic fluid.
So the drug gets where it needs to go.
It gets where it needs to go. It doesn't guarantee prevention, obviously, but it proved the drug presence was there. So that's a pivotal insight right there. The treatment's efficacy, which was a major question mark, now looks like a cornerstone of a potential screening strategy.
That's fascinating. So it wasn't just brand new data, but maybe a fresh look at existing data combined with these new pharmacokinetic insights. How did that translate into feeling more confident about treatment? And I imagine the financial side, the economics, also played a big role in this reevaluation.
They absolutely did. And here's maybe the clincher. The economic argument completely flipped.
Mhm.
There was one French study by Perel Dubois and colleagues that found a generalized screening strategy, when combined with velaciclover treatment, actually dominates the current practice.
Dominates. What does that mean exactly?
It means it's better and cheaper, essentially. In terms of avoided congenital infections, it came out ahead with a differential cost-effectiveness ratio of just 893 euros per avoided congenital infection compared to doing no screening at all.
Wow. So it's not just clinically better, it actually makes economic sense from a public health perspective.
Precisely. It wasn't just about saving lives or preventing disability, though that's paramount. It proved to be the smarter public health investment. The benefits now seem to clearly outweigh the costs.
That's a powerful combination. Strengthened clinical evidence and a clear economic advantage. But CMV, as we said, has such a profound impact on individuals and families. What did the patients themselves, through their associations, say in this reevaluation? That perspective must have been incredibly important.
Oh, absolutely crucial. The voice of patient associations, particularly those specialized in CMV, was powerful and very persuasive. They expressed a globally favorable view towards systematic screening.
They were for it.
Generally, yes, provided there's clear, comprehensive information and, importantly, adequate training for healthcare professionals involved.
That makes sense.
They shared experiences of, frankly, a profound lack of support and significant trust issues when diagnoses were made late, often after irreversible damage had already occurred.
Heartbreaking stories, I imagine.
Yes, and the Fondation pour l'Audition also underscored the importance of screening, really hammering home CMV's role as the main non-genetic cause of congenital deafness. Their perspectives truly highlighted the human cost of delayed or absent screening. It put a face to the statistics.
It really sounds like the collective understanding, the perceived benefits, have grown significantly across the board from the medical community, the economic analysts, and most importantly, the patients themselves.
Exactly. The medical community, including infectiologists, is now progressively adopting this therapeutic approach. You see experts actively advocating for systematic screening now, emphasizing the need for organized and consistent management to empower women to help them make informed decisions.
Right, giving women the information.
Precisely. They point out the striking disparity in information provision for CMV compared to other conditions we screen for, like trisomy 21 or toxoplasmosis. They assert that women have a fundamental right to be informed about CMV right from the beginning of their pregnancy.
To allow for true autonomy?
Exactly. True autonomy in their choices and, crucially, access to care if needed.
So, given all these shifts, the science, the economics, the patient voice, what does this all mean for daily practice? The path forward seems clear, maybe towards screening, but are there still hurdles? Implementing such a big change across a national healthcare system can't be simple.
No, it's definitely not simple. And this raises that important question. How do we actually translate these findings into equitable and effective practice across all of France?
Yeah, the practicalities.
The HAS report itself highlights the necessity for harmonized practices, everyone doing it the same way, a significant reorganization of care pathways, how patients move through the system, and definitely reinforce training for all healthcare professionals involved.
Training is key. Yeah.
Absolutely. And while those ethical concerns about anxiety from false positives and the burden of prolonged treatment for the woman, they do persist, and there are valid considerations we need to manage.
Of course.
The emphasis now is firmly on providing clear, transparent, and loyal information, as they put it, to women, allowing for truly informed consent and shared decision-making.
So, partnership with the patient.
Exactly. That window of opportunity for intervention, yes, it remains narrow, but early detection, followed by effective intervention, is increasingly seen as achievable and ultimately beneficial. It just requires continuous learning and adaptation from all of us on the ground.
This deep dive truly reveals a compelling evolution, doesn't it? In the whole approach to congenital CMV screening in France. From that cautious stance of the HCSP back in 2023
Mm-hmm.
to the much more proactive, nuanced recommendations of the HAS in June 2025. The scientific and clinical landscape is undeniably shifting.
It really is. The new, more robust data on Vlastaclovir's efficacy in preventing vertical transmission, you couple that with a stronger economic argument, and the growing, powerful support from patient advocacy groups, those who've played a crucial role.
Yeah.
For healthcare professionals like you listening, this means a potential future where systematic screening offers a tangible pathway to significantly reducing the severe, often lifelong, sequelae of CMV.
The challenge now, it seems, lies in translating this evolving knowledge into widespread, accessible, and really well-supported clinical practice.
That's the next step.
So, as you reflect on all this, maybe consider this provocative thought. In this ever-evolving world of medical knowledge, how do we best balance the individual's right to comprehensive information and effective intervention with the, let's face it, complexities of implementing population-level public health programs effectively and equitably for everyone?
That's the million-dollar question, isn't it?